Hi guys, welcome back to the Master ECG Series. I'm Dr. Patil and we're continuing our discussions on the ECG. So today we will be talking about arrhythmias. We will split the discussion on arrhythmias over 3 to 4 sessions. Today we will spend 20 minutes understanding some fundamentals or basics of arrhythmias. Not important from the perspective of exams. Nobody will ask you the concepts behind arrhythmias. But still, if you have the basics clear, then understanding the true arrhythmias becomes little more easier. Okay. So now I will start with a one simple question. What do you mean by an arrhythmia? Well, life has a rhythm which is set by the SA node, right? So heart has a rhythm and heart's dominant or the main pacemaker is the SA node, and whatever the rhythm that follows, we call it as the normal rhythm, right? Okay, so then what is arrhythmia? Any deviation from the normal sinus rhythm, we will call it as arrhythmia, right? So first we will understand what is arrhythmia. Arrhythmias are deviations from the normal sinus rhythm. Deviations from normal sinus rhythm. That begs a question, what is normal sinus rhythm? And is there any difference between the sinus rhythm and a normal sinus rhythm? Are they same or are they different? Okay, let me give you an example. Now I sit here and start meditating, right? I go in a trance like state. My heart rate will start coming down, right? It will drop to, let us say, 45, 50, or I am in deep sleep, my heart rate will be 50. Okay. Now, in that case, who is the dominant pacemaker of my heart? Yes, it is SA node, right? So SA node is the pacemaker. Now, can I call this situation as normal sinus rhythm when my heart rate is 40, 45, 50? And SA node is the dominant pacemaker. Can I call it as normal sinus rhythm? No. We will call it as sinus rhythm, but I will not call it as normal sinus rhythm. Why I will not call it as normal sinus rhythm? To call it as normal sinus rhythm, the first thing I need is SA node should be the pacemaker. SA node should be the dominant pacemaker. Okay, so the example I gave where I'm meditating and my heart rate is low, still SA node is the dominant pacemaker. I don't have any AV blocks or something. So of course, this first criteria is met. Okay, clear? Second, if SA node is the pacemaker, there should be no other accessory pacemaker functioning, right? So in that case, if I look at the ECG, right, P wave should be present or absent. When SA node is the pacemaker, SA node is sending a wave of depolarization across the atria. Of course, P waves will be present. P wave should be present. They should be morphologically distinct and identifiable, right? Okay. Now, if P wave is there, then ventricle will follow with QRS, right? Ventricle will follow with QRS, and then each P wave should be followed by a QRS, followed by a QRS complex, and the vice versa is also true. If I get an ECG, I catch hold of one QRS. If it is normal sinus rhythm and SA node is of course the pacemaker, when I look behind the QRS, there should be a P wave, right? So each P should be followed by QRS. That tells that there is no AV blocks, and behind every QRS there should be a P wave. So that tells me that this QRS is not generated by a pacemaker sitting in the ventricle, but by a pacemaker from the atria, which is SA node. In other words, I can express it this way. If I look at any ECG and I look at the ratio of P and QRS, if it is normal sinus rhythm, right, it should turn out to be 1. It should turn out to be 1. For 1 P, there should be 1 QRS. Okay. Last but not the least, if I meet all these criteria, that is SA node is the dominant pacemaker, I have morphologically normal looking P waves, and each P is followed by QRS. Behind QRS, there is a P. It only tells me that SA node is the pacemaker. It doesn't tell me that this is normal sinus rhythm, right? So with this criteria, I will call it a sinus rhythm. Now with this sinus rhythm accompanied by a heart rate of 60 to 100 per minute, then I will call it as normal sinus rhythm. So I was giving you an example, right? Like I am in a deep meditative state and my heart rate is dropped down to 45. Now can I call it as normal sinus rhythm going by this criteria? No, my heart rate is less, right? So it is not normal sinus rhythm. Then what will I call that circumstance as? Pacemaker, even in a meditative state for me, when I don't have any structural problems with the heart, is still SA node. So rhythm is set by SA node. but rate is less than 60. So I will call that condition as sinus bradycardia. Sinus bradycardia is not normal sinus rhythm. It can be physiological. When I'm in a meditative state or in deep sleep, there is physiological bradycardia, right? A lot of athletes, we know they can have bradycardia. That is physiological, right? Similarly, if I get excited or if I get damn scared of something happening around in the environment, my heart rate will shoot up, right? That's what happens when your girlfriend or boyfriend detects your lies, right? Your heart rate shoots up. Still, pacemaker is SA node, so you have sinus rhythm, but not normal sinus rhythm. In that case, heart rate more than 100, you will have sinus tachycardia, right? So now we have a clear idea of what is arrhythmia and what is normal sinus rhythm. So what is normal sinus rhythm? Normal sinus rhythm is where the rhythm is initiated by the SA node, that is the dominant pacemaker. And if SA node is initiating the rhythm, there should be P waves, and each P should be followed by a QRS. Behind any QRS, there should be a P wave. So if I look at a P by QRS ratio in ECG, it should turn out to be 1, and the rate should be 60 to 100 minute. If the upper three criteria are met but rate is less than 60, I will call it a sinus bradycardia, and if it is more than 100, I will call it a sinus tachycardia. Now, in a patient where these parameters are not met on ECG, then we will call it as arrhythmia, deviations from normal sinus rhythm, right? Sinus bradycardia is also an arrhythmia. Sinus tachycardia is also an arrhythmia, apart from all other arrhythmias that we know, right? Clear? So now we know what is an arrhythmia. We will understand mechanisms behind arrhythmias, why arrhythmias happen in a given individual. Okay. Broadly, arrhythmias can be classified based on the rate as bradyarrhythmias when heart rate is less than bradyarrhythmias when heart rate is less than 60, and when I have deviation from sinus rhythm with heart rate more than 100, we will call them as tachyarrhythmias. Tachyarrhythmias when heart rate is more than 100. Okay. Now, can anybody give me an example for a bradyarrhythmia? Of course, sinus bradycardia is an example. Then in this ECG series, so far we have discussed about AV blocks, right? First degree, second degree, Mobitz type 1, Mobitz type 2, third degree AV blocks. All of them are classical examples for bradyarrhythmias. Okay. And then tachyarrhythmias, you might have heard about atrial fibrillation, paroxysmal supraventricular tachycardia, ventricular fibrillation. They're all tachyarrhythmias. Okay. Now, what can be the mechanism? Why someone develops an arrhythmia? To understand that, let us take a quick look at the conduction system of the heart, right? Let us say this is my heart. So we all know that SA node acts as the dominant pacemaker. SA node initiates an impulse. That impulse from the SA node will reach the AV node, right? On the way, it will definitely cause depolarization of the atria. That will give rise to a P wave on the ECG. Then once it reaches the AV node, there is a delay that gives me the PR segment. After that, the impulse is conducted through His bundle, which divides through bundle branches, Purkinje fibers, to eventually cause depolarization of the ventricles. And that ventricular depolarization will give rise to QRS complexes. And after that, ventricle will get repolarized. It will recover from this depolarization. Okay. Now, how do my body decide that my heart rate should be between 60 to 100? How body decides that heart rate should be maintained 60 to 100? That is the normal automaticity of the SA node. So SA node by default keeps firing the impulses at a rate of 60 to 100. This we have discussed in one of the previous ECG module also, right? Okay. But then I gave you an example. When I go into meditation, my heart rate comes down. When I get scared or excited, my heart rate goes up. SA node itself is still the pacemaker. So then how heart rate is increasing or decreasing? How is it increasing or decreasing? This SA node, though its normal automaticity is set between 60 to 100, it is influenced by other factors. What are those other factors? Mainly your autonomic nervous system, right? So as we know, SA node has an automaticity, right? We will call that impulse generation as automaticity. This automaticity can be stimulated or influenced positively by the sympathetic nervous system and negatively by the parasympathetic nervous system. So when I go into a meditative state, when I'm calm, right, my vagal nerve, which is part of our parasympathetic nervous system, its tone increases. So vagal nerve activity increases. So that suppresses the automaticity of the SA node. So my heart rate comes down. SA node is still the pacemaker, but its automaticity rate has dropped down below 60. That's how my heart rate is going down. Now, when I'm scared, we all know that as fight, flight, fright response, the sympathetic nervous system gets activated. So the sympathetic nervous system, the adrenaline, noradrenaline, they will stimulate the SA node to increase its automaticity. So the rate now can step ahead of the 100 per minute, right? So if my natural response suppresses the SA nodal activity and rate drops below 60, still SA node is a pacemaker, so that's why I'm going to call it as sinus bradycardia. And when heart rate increases above 100 because of increased sympathetic drive, still SA node is the pacemaker, so I will call it as sinus tachycardia, right? But normal automaticity is set at 60 to 100. Now, in sinus bradycardia, what is happening? There is decreased automaticity, right? So that is one of the mechanism. One of the mechanism for bradyarrhythmia is decreased automaticity. Decreased automaticity. Decreased automaticity, right? Examples we can say, right? Increased vagal tone. Vagal tone. Sometimes we say this vagal shock or vasovagal shock, right? That is where the vagal tone suddenly increases, dropping the heart rate to a critically low value, where maintaining the cardiac output becomes difficult. So your brain doesn't get perfused, so you can feel dizzy and develop syncope, right? That is one mechanism where we can develop bradyarrhythmias. The second mechanism we can develop bradyarrhythmias is, let us say, I can say increased vagal tone or decreased sympathetic nervous system tone. The second thing is I can develop a AV block, or I can even develop the damage to SA node. So if I cause damage to SA node, the automaticity will automatically come down, right? Or I can block AV node. So if I'm blocking, the number of impulses that are going through this block to the ventricle will come down. That is what we call as AV blocks, right? So decreased conduction is another mechanism. So one mechanism is decreased automaticity, the other mechanism is decreased conduction. Decreased conduction, the classical example we're going to quote here is the AV blocks. AV blocks. So of course, in the first degree AV block, there is no missed QRS because there is only delay in the AV nodal delay is increased. But in case of second degree block onwards, of course, we will have missed QRS. So then that means the heart rate is significantly come down. Okay, so these are the mechanisms for bradyarrhythmias. Now, what can cause tachyarrhythmias? Same, we can think of the mechanisms on the similar grounds. One is increased automaticity. Increased automaticity. What can increase the automaticity? The opposite of what decreases the automaticity, right? Like decrease in the vagal tone or increase in the sympathetic drive. See, for example, coffee, consuming too much of coffee is known to trigger arrhythmias, tachyarrhythmias. How? Because caffeine is a stimulant, right? So caffeine can stimulate your SA node to increase the automaticity. Cocaine can do the same thing, right? So that is why these like stimulant drugs are known to kill people when they are in sleep, right? They take drugs, go to bed, then next day morning they're found dead. One of the mechanism is developing arrhythmias by increasing automaticity. Okay, so that is one. What else can trigger the arrhythmias? Second, a lot of patients have arrhythmias which are because of electrolyte abnormality. So such cases are usually because of triggered activity. Now, what do I mean by triggered activity? Triggered activity. Normally, when we look at the action potential of the heart, right, we have these different phases: the depolarization, early repolarization, plateau, and then delayed repolarization. After that, we are in, like, the next complex will appear after some time. There is a time gap. Now, I can trigger another event of depolarization, and that can cause arrhythmias. We'll discuss more on this in a bit. Okay. And the third mechanism, if an impulse, let us say, travels, an electrical impulse, let us say it travels from the atria to ventricle, right, through the usual pathway. But if I create See, normally I have already told you multiple times that the cells which separates the atria from the ventricle are formed of tight junctions. So whatever electrical activity that happens at the level of atria cannot percolate into the ventricle. It never reaches the ventricle directly, and this AV node is the only window through which atrial electrical activity can reach the ventricles, right? But if I have some breach here, right, let us say there is a breach. In that case, whatever electrical activity that happens in the atria may be able to reach the ventricle bypassing the AV node. But if it reaches the ventricle, this pathway may be much faster than the pathway that is regularly traveling. So if that is the case, ventricle will get depolarized early, and from this, the electrical impulse may retrogradely travel back into the AV node or into the atria and trigger one more depolarization of the atria. The one depolarization happened because of the SA nodal impulse, but now the re-entry of this electrical impulse because of this accessory pathway is triggering one more depolarization. So now what happened to the heart rate? Of course, it increased, right? Because one regular depolarization, one triggered by re-entry circuit, and this circuit can self-sustain. In that case, the arrhythmia will go on and on for quite some time. Now, what can I call this mechanism where there is a re-entry of electrical impulse? We will call it as re-entry circuits. Re-entry circuits. So these are the three mechanisms where tachyarrhythmias can be triggered. Majority of the electrolyte imbalances cause triggered activity. Re-entry can happen if you have an accessory pathway or sometimes without an accessory pathway. We'll discuss more on that. Automaticity of the normal conducting system itself can be enhanced by drugs, not only the abusive drugs, even the pharmacological drugs that we use for treatment and various other electrolyte abnormalities. Also change in the sympathetic and parasympathetic drive. They can all trigger tachyarrhythmias. Clear? Okay. We will learn a little bit more on the tachyarrhythmias and mechanisms. This I hope is clear. Bradyarrhythmias, either I can decrease the automaticity of the conducting system, especially SA node, or I can cause conduction blocks, right? That causes a decrease in the conduction. Okay. Now talking about the tachyarrhythmias. The first thing we were talking about was the abnormal automaticity. So what can cause the abnormal automaticity? One, there can be increased automaticity, or there can be development of an ectopic pacemaker. Ectopic pacemaker. Increased automaticity, a classical example I can quote where your SA node is still the pacemaker, but its automaticity rate is increased, as in case of sinus tachycardia, right? So example is sinus tachycardia due to either increased sympathetic nervous system activity or decreased parasympathetic nervous system activity. Now, ectopic pacemaker, when it can happen? See, normally the atrial or ventricular myocardium, right, is not capable of generating a pace, right? They are not pacemakers. Only AV node, SA node, internodal pathways, Bachmann's bundle, his bundle, bundle branches, and Purkinje fibers can generate a pacemaker potential. But some individuals, either because of structural abnormalities of the heart or damages to the heart, right, the myocardial cells might acquire the ability to initiate a pacing or pacemaker potential. So thus they can become an extra pacemaker. That's what we call as an ectopic pacemaker. A classical example is atrial fibrillation. So in atrial fibrillation, if this is my left atrium, there are entry points for the pulmonary veins, right? Pulmonary veins are coming from the lungs. So around these entry points for the pulmonary veins, there is some area where the atrial myocardium can acquire pacemaker capabilities, and it now becomes an additional pacemaker. So now it becomes an additional pacemaker. So my SA node is sending the impulse for the regular, but there is also an ectopic focus which is sending additional impulses. So that is why atria will now be getting depolarized from the regular SA nodal pacemaker as well as this ectopic pacemaker, and its automaticity may be much higher than the normal SA node 60 to 100. So now that is how I can end up with atrial fibrillation. I hope you're getting the point, right? So ectopic pacemaker is another mechanism where abnormal automaticity can be noticed. Then second, we were talking about triggered activity, right? Triggered activity. This is a bit complex. As an undergraduate student, you don't need to break too much of your head, but I'll give you a gist of it, what I mean by triggered activity. Normally, we have a phase 4, which is the resting membrane potential of the cardiac action potential. Then we have phase 0 where depolarization happens. Then we have phase 1 where early repolarization happens. Then we have phase 2, which is plateau phase. Then we have phase 3, which is delayed repolarization. Again, we enter into the phase 4, which is resting membrane potential. And as we know, all of these variations in the membrane potentials are because of electrolytes, right? Some electrolytes are either getting into the cell or they're leaving the cell, and that is why the action potential is changing. So as we know, entry of sodium inside the cell causes the depolarization of the cardiac myocyte, right? Then repolarization, early repolarization is because of potassium leaving, delayed repolarization is also because of potassium leaving, and phase 2 particularly is because of one, calcium entering the cells and potassium leaving the cell. So there is a balance between calcium entering the cells and potassium leaving, and that's why there is no net change in the membrane potential. So we will maintain the membrane potential as it is. That is the plateau phase. Okay, so just take the example of the plateau phase, that is phase 2. So during this period, if I interfere with one of these, right, there's a balance between amount of calcium entering the cells and potassium leaving out. Let us say that I block the potassium leaving out from the cells. So more and more calcium is entering. Potassium leaving the cell causes repolarization, right? And calcium entering is kind of causing depolarization because both of them are balanced. We are maintaining the membrane potential. But now I have blocked the potassium leaving the cell. So in that case, calcium entering the cells will trigger another event of depolarization. So here I will start seeing another episode of depolarization. So now I have one early, we will call it as early after depolarization. So if I interfere with the calcium potassium, I can end up getting early after depolarization, which will now trigger an arrhythmia. Okay. Similarly, this maintenance of resting membrane potential primarily depends on efflux of sodium. All the sodium that had come into the cell, we pump out, and whatever potassium we had pumped out during the early and late repolarization, we take it back into the cell through sodium potassium ATPase, right? Now, if I interfere with this, right, if I either inhibit potassium entering the cells, like if I interfere with this sodium leaving the cell or potassium entering the cell, again I can trigger one more action potential here. Literally, I can cause depolarization by inhibiting the potassium leaving the cells or by increasing the potassium entering the cell, and thus I can trigger one more depolarization. Now this depolarization is happening after the phase 3, that is, it is happening at phase 4. So this depolarization, we will call it as late after depolarization. Late after depolarization. Now what can cause these early or late after depolarization? Of course, it is the electrolyte imbalances or channelopathies, right? There is a sodium channel, potassium channel, calcium channel, sodium potassium ATPase. If I have channelopathies or electrolyte abnormalities, there can be triggered activity which can trigger an arrhythmia, right? So that's why managing electrolyte imbalances efficiently is important for us. Okay. Then there is a third mechanism. This is a mechanism as an undergraduate you are supposed to be more aware of. Even if you don't understand what is triggered activity, you don't understand what is early after depolarization, late after depolarization, it's fine. But you should know the abnormal impulse conduction or the re-entry circuits, right? This abnormal impulse conduction, I can call it as re-entry circuits. We will take an example of a supraventricular arrhythmia, which is called as AV nodal reentrant tachycardia. I'm just taking an example. All these arrhythmias we'll discuss in detail later. Okay, so this is an arrhythmia where exactly what happens is atria, its pacemaker is SA node, right? So SA node sends an electrical impulse. It will of course cause the atrial depolarization, cause a P wave. And then once this enters the AV node normally has two pathways within it. So one conducts faster. This we will call it as the fast conducting pathway. This is fast pathway. So impulse travels through this much faster. And then we also have a slow conducting pathway where impulse travels little slow. Slow conducting pathway and fast conducting pathway. Now, normally what happens, the impulse that travels a fast conducting pathway will reach the His bundle. This is my His bundle, right? So it will reach the His bundle before the impulse traveling from the slow pathway. Okay. Now, physics tells me that electricity will travel in any direction where there is potential difference. So if the impulse is traveling from the fast conducting pathway and reaching here, of course, it will go down because there is potential difference and it will pass through the bundle branches, Purkinje fibers and cause the ventricular depolarization. Okay. But the slow conducting pathway, the impulse might have reached here, right? Because it is traveling slow. So then in this impulse, because there is a potential difference, the impulse will travel upwards into the slow conducting pathway. In normal physiological state, what happens? Remember, in normal physiological state, the slow impulse coming from the SA node and this impulse re-entering from the fast conducting pathway, they will cancel out each other. So you can say virtually the slow conducting pathway is non-existent. Means it is there, but whatever slow impulse is coming through it is not going to reach the ventricle because the fast impulse will reach the ventricle ahead and the retrograde conduction will cancel out the slow impulse. Okay, where the problem comes, the problem can happen in certain circumstances, and to understand that problem we need to know one extra point. This fast conducting pathway has a relatively longer refractory period. Means once an impulse passes through it, you know that there is a refractory period. Next impulse cannot be immediately traveling through this pathway. So it has a long refractory period. For the next impulse to come, next impulse to be conducted through it, it needs a gap. On the other hand, the slow conducting pathway has a very short refractory period. So it gets ready for the next impulse much faster than the fast conducting pathway. Now let us say for some reason there is an atrial ectopic. Now what do I mean by atrial ectopic contraction? We just learned that certain drugs like cocaine or caffeine, they can stimulus or they can trigger an ectopic focus to become the pacemaker, right? Let us say that something of that sort happened or atria contracted little early. Like let us say, okay, so I am now talking to you, I am at a stable heart rate, but then suddenly I get scared because I heard a blast somewhere, right? Now my sympathetic nervous system will get activated and it will activate the SA node. So now SA nodes automatically increase. SA nodes will start firing faster. So now the next atrial impulse that is going to come, it may come much earlier than the anticipated period. So once the next atrial impulse comes, it may not be able to enter the fast pathway. Why? Because fast pathway may be in the refractory period because it has a long refractory period, right? Then what will happen? It will enter the slow pathway, and it will slowly reach the end of the AV node. By this time, fast pathway might have come out of its refractory period. It is now ready to conduct, right? And now this place has higher potential than the fast pathway. So now the impulse can travel back from the fast pathway and it can go to atria, cause atrial contraction. It can also travel down to cause the ventricular contraction. So why this happened? Just because I caused an atrial premature contraction. So the impulse arrived early to the AV node than usual. And when it arrived early, it caught the fast pathway in the refractory period. So impulse could not travel through the fast pathway. So it traveled through the slow pathway because slow pathway has short refractory period. So it was already ready to receive the impulse. So it came through the slow pathway. From the slow pathway, it can now enter back into the atria and cause atrial depolarization, as well as it can go down to the ventricle to cause ventricular depolarization. So now what happened to the atrial rate? Atria got depolarized earlier from SA node. Now this is an extra atrial contraction because of this re-entry, right? Now where is all this re-entry happening? Re-entry is happening at the level of AV node itself. That's why it is called as AV nodal re-entrant tachycardia. There are two types of AV nodal re-entrant tachycardia: slow fast and fast slow, depending on whether it travels from the slow to fast or from the fast to slow. Most commonly it is slow fast AV nodal re-entrant tachycardia, means impulse travels from the slow and then re-enters through the fast pathway. 95% of AV NRT are slow fast. 5% can also be because of fast to slow. Clear? Now the re-entry circuit need not always happen through the AV node. It can also happen through ectopic pathways. For example, we have studied that there is WPW syndrome, right? So what is happening in WPW syndrome? Normally the atrial electrical activity cannot pass to the ventricle. It can only pass through the AV node. But in case of WPW syndrome, there is an accessory pathway through which the impulse can enter into the atria, right? So it can from atria to ventricle. So now this is a fast pathway because there is no bypass, right? This AV node is causing the delay, so this pathway may be conducting slower. So early impulse reached the ventricle, it caused it depolarization. That is what we have seen as delta wave on the ECG. Now from here the impulse can re-enter into the atria and cause a extra atrial contraction. So re-entry need not always happen through this slow fast pathway within the AV node. When it is happening within the AV node, we will call it as AV nodal re-entry tachycardia. When this re-entry circuit is formed by an accessory pathway, we will call it as AVRT. AVRT. AV reciprocating tachycardia. AVRT. So in WPW syndrome, the kind of arrhythmia that we get is AVRT. Okay, so I hope we have clarity about the abnormal impulse conduction or re-entry circuits. Re-entry circuits can either be because of the normally existing fast flow pathways in the AV node with triggering of the arrhythmias by a early arrival of the atrial impulse, or it can be because of an ectopic pathway or an accessory pathway through which the re-entry can happen. So these are the mechanisms for arrhythmias, right? So to summarize again, bradyarrhythmias can happen because of decreased automaticity or decreased conduction. Tachyarrhythmias can happen because of increased automaticity or triggered activity, mainly because of electrolyte abnormalities or re-entry circuits. Re-entry circuits may be situated in the AV node itself, that causes AVNRT, or it may be because of an accessory pathway. So this re-entry circuit is formed by an additional pathway that causes AVRT. Clear? So these are the mechanisms of arrhythmias. Now today we will discuss a little bit about the classification of arrhythmias, and then in the next session, that is tomorrow, we will discuss about the ECG recognition of arrhythmias. Okay. So classification of arrhythmias. The arrhythmias can be classified, as we have already discussed, as bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias and tachyarrhythmias. So any arrhythmia where the rhythm is not normal sinus rhythm, right? Rhythm is not normal sinus rhythm will be an arrhythmia. If the heart rate is more than 100, we will call it as tachyarrhythmias, and if the heart rate is less than 60, we will call it as bradyarrhythmias. Heart rate less than 60 per minute, we will call it as bradyarrhythmias. Okay. Now, bradyarrhythmias, if you ask me examples, right? What are the examples for bradyarrhythmia? The first example we should quote is always sinus bradycardia. Sinus bradycardia. So what does sinus bradycardia mean? The pacemaker is sinus node. That's why we're calling it as sinus. So the number of P's and the number of QRS will always be equal. Will always be equal. But rate is not what I can call as normal sinus rhythm. To call it as normal sinus rhythm, pacemaker should be sinus node and rate should be 60 to 100. But when the rate is less than 60, despite having SA node as the pacemaker, we will call it as sinus bradycardia. And this is the most common bradyarrhythmia. Sinus bradycardia is the most common bradyarrhythmia. There are n number of causes for sinus bradycardia. It is physiological in many cases. For example, in athletes, right? In yogis, it is physiological. It can also be pathological. For example, drugs, right? We know that beta blockers cause sinus bradycardia. Calcium channel blockers, especially the non-dihydropyridine calcium channel blockers, can cause bradycardia. So there are a lot of pathological as well as physiological causes for sinus bradycardia. Okay, then SA node dysfunction. So automaticity of the SA node can be reduced for if there is a damage to SA node or there is reduced blood supply to SA node. So you can call it as SA nodal disease, six sinus syndrome. And then if SA node is working fine, but AV node is not able to pass down the impulse, there are AV blocks, then also I can have bradyarrhythmias. Okay. So I hope you will be able to recognize the AV blocks. So from this bradyarrhythmias, it is mainly for an undergraduate student, your ability to detect different degrees of AV blocks. That is what is tested in the exam. Coming to the tachyarrhythmias. These tachyarrhythmias, we will divide them into two broad groups. What are the broad groups? We will divide them into supraventricular arrhythmias and ventricular arrhythmias. Supraventricular arrhythmias and ventricular arrhythmias. Now, what is the basis to call it as ventricular arrhythmias or supraventricular arrhythmia? So whatever is an arrhythmia, there is an abnormal rhythm, right? So whether that rhythm is generated in the atria or whether it is generated in the ventricle, on that basis we will call them as supraventricular arrhythmias or ventricular arrhythmias. For example, we were talking about this AVNRT, right? So where is the trigger happening? In the AVNRT, the impulse travels from the slow pathway, right? Circuits back through the fast pathway, go to the atria and triggers an additional atrial contraction, right? So the abnormal activity is happening, means the rhythm is primarily affecting the atria. So we will call it as supraventricular tachyarrhythmia. Similarly, AVRT, right? Through an accessory pathway, it is circuiting back and causing the increased activity of the atria. So this will also be a supraventricular arrhythmia. But let us say that some part of my myocardium, ventricular myocardium, becomes an ectopic pacemaker. We have discussed that ectopic pacemakers can also be a reason for enhanced automaticity. So now this ectopic pacemaker is setting the rhythm. So it will primarily affect the ventricles because the pacemaker is situated in the ventricles. So then in that case, I will call it as ventricular arrhythmia. So what comes under the supraventricular arrhythmias? So in the supraventricular arrhythmias, the most common supraventricular arrhythmia is sinus tachycardia. Why? Because pathology rests above the ventricle. Sinus tachycardia means increased automaticity of the SA node itself. And where is the SA node situated? Of course, above the ventricle in the atria. So sinus tachycardia is the most common supraventricular arrhythmia, right? So this is the most common supraventricular arrhythmia. In fact, among all the arrhythmias, brady, tachy, everything put together, sinus tachycardia is the most common arrhythmia. All of us have gone through it. Before seeing our exam results, right, you type your roll number and your result sheet is opening, your heart rate shoots up. You are going through sinus tachycardia, right? So when in the Viva OSCE, teacher asks some question and he's staring at you, your heart rate shoots up. So you are going through sinus tachycardia. Sinus tachycardia is the most common arrhythmia overall. Okay. Then we have AVRT and AVNRT. Collectively, both of them are simply called as supraventricular tachycardias or SVTs. Because they occur intermittently, we call them as paroxysmal supraventricular tachycardias. Okay. So then I have atrial fibrillation. atrial fibrillation or AFib. And then we have one more, which is atrial tachycardia. Atrial tachycardia. So these are all our supraventricular arrhythmias. It's there in the name, right? Sinus tachycardia. The moment I say sinus, you know that problem is above the ventricle, right? AVRT and AVNRT, we have discussed the mechanism. Everything is looping back to go to the atria. Problem is at the level of atria. Atrial fibrillation, it is there in the name. Atrial tachycardia, it is there in the name. Okay. Now, what are ventricular arrhythmias? The ventricular arrhythmias that I can name, one of them is ventricular tachycardia, right? VTAC or VT. The second one is ventricular fibrillation or VFib. VFib. These are ventricular arrhythmias. Now you may be asking, sir, where is atrial flutter in this discussion, right? Or some of you may be thinking, sir, where is multifocal atrial tachycardia, MAT? We have heard about it. They all come under atrial tachycardias. Atrial tachycardias have some subtypes. Okay, we'll discuss all of that tomorrow. So today, what we have understood, we have bradyarrhythmias and we have tachyarrhythmias. We should be able to recognize all of them on the ECG. So I'll give you a basic approach today, and then tomorrow we will discuss individuals. So if I have to suspect arrhythmia in a patient, when can I suspect? Well, when can you suspect arrhythmia? When, number one, heart rate is more than 100, right, or less than 60. Of course, that means it is not normal sinus rhythm. Patient may be in either sinus tachycardia, sinus bradycardia, or patient may be having one of the bradyarrhythmias or tachyarrhythmias we just discussed, right? Like AV blocks, SA node dysfunction, or VT, VF, atrial fibrillation. So this is first condition where you can suspect patient may be in arrhythmia. Okay. Second, how did we define normal sinus rhythm? Remember, in normal sinus rhythm, when I look at the ECG, the dominant pacemaker is SA node. In that case, there should be identifiable P waves. So if morphologically distinct identifiable P waves are not there, that means patient may be in arrhythmia, right? And then if I identify P waves, the number of P waves should be equaled by the number of QRS. So if there is deviation, again I should suspect arrhythmias. So in any ECG where there are absent P waves, you are suspecting arrhythmias. Or if the third, number of P waves are not equal to number of QRS, either one of them is more, QRS is more or P is more, they are not equal, then you will suspect arrhythmias, because these are all deviations from the normal sinus rhythm, right? Okay. So if I get a patient where heart rate is either more than 100 or less than 60, or I observe that P waves are absent, or the number of P and QRS are not equal, I suspect arrhythmias. Now I'm suspecting arrhythmias, how will I take it to diagnosis? Step number one, I need to know whether it is bradyarrhythmias or tachyarrhythmias. If it is bradyarrhythmias, it is pretty simple, right? As an undergraduate student, don't worry about the SA blocks. Concentrate on sinus bradycardia and AV blocks. Sinus bradycardia, you know, right? The rhythm is sinus, so number of P will be equal to number of QRS, but heart rate will be less than 60. Means it looks like normal ECG, but low heart rate. But in case of the AV blocks, except the first degree AV block, because there are missed QRS, the number of P waves will be more than the number of QRS. Number of P will be, because SA node is functioning fine, SA node is sending the impulse, but AV node is not able to conduct it to the ventricles intermittently. So in that case, every time atria get depolarized need not result in ventricular depolarization. So there will be some missed QRS. All the P's will be there, but QRS will be missed. So number of P will be more than QRS. And heart rate in such cases is usually going to be less than 60 if it is AV blocks, right? So now we will primarily focus on tachyarrhythmias. This you are very much familiar how to recognize first degree, second degree, third degree AV blocks, and sinus bradycardia is not a difficult to diagnose ECG. We will concentrate on tachyarrhythmias. If I am having tachyarrhythmias, what I should focus on? First thing I have to do is I need to know whether it is supraventricular arrhythmia or ventricular. Now, if you're asking me, why is it important, sir, to know whether it is supraventricular or ventricular? Okay, let me tell you. Which one is most dangerous? Is it ventricular or supraventricular? Is it ventricular or supraventricular? Let us take two examples. Atrial fibrillation, which is supraventricular, right? And ventricular fibrillation, which is ventricular arrhythmia. Which is more dangerous? Whenever we hear the fibrillation, we know that fibrillation means shaking or vibrating, means the atria or ventricle, whichever is fibrillating, is only shaking or vibrating, is not contracting with sufficient force. So in atrial fibrillation, atria is getting depolarized multiple times from this ectopic focus apart from the SA node. So atrial rate is very high, but the voltage delivered to atria from the ectopic focus is not sufficient for us to trigger its contraction. So atria, with whatever voltage we are giving it, it can only shake or vibrate. So it is vibrating, not contracting. So if it is not contracting, will I be able to push the blood from atria to ventricle? Yes or no? Will I be able to push the blood from atria to ventricle? Well, we don't depend too much on the atria pushing the blood to the ventricle. Why? When I transfer blood from atria to ventricle, I transfer it during diastole. It happens in two phases. One of them is passive filling and the other one is active filling. So I do passive filling, which accounts for 70 to 80% of ventricular filling, and that is passive filling. And 20 to 30% of the blood that I fill into the ventricle, that happens through active filling. That is where atria contracts. So only 20 to 30% of blood transfer from atria to ventricle is because of atrial contraction. Rest of them is not because of atrial contraction. It is passively coming from atria to ventricle because of the pressure gradient. So if my atria doesn't contract, what is my loss? I may not be able to fill this 20 to 30%, but 70 to 80% still I will be able to fill. So ventricular filling is not largely compromised. It's partially compromised, right? But still 70 to 80% blood will still come to the ventricle that it will eject. But now think about it. What if my ventricle doesn't contract? Whatever blood I have filled from atria to ventricle, right? Now I have to eject it through the... Is there any passive ejection? No, right? Ventricle has to actively contract to eject this blood. If my ventricle is not contracting, it is only vibrating, will I be able to eject the blood? Of course not. So this ventricular ejection is compromised. That means the amount of blood I'm ejecting to the aorta, that is stroke volume, that has come down. Indirectly, cardiac output has come down. So now there is no sufficient blood going to my brain, kidneys, liver, so my organs will start failing. So most of the ventricular fibrillations, these patients will not have pulse at the time of arrival to emergency room because their ventricle is only shaking. It is not contracting to push the blood to the tissues, right? So I may die within seconds to minutes after the onset of ventricular fibrillation. I can comfortably survive with the atrial fibrillation. I have a lot of patients who are having chronic atrial fibrillation. They're living with atrial fibrillation. They're living with atrial fibrillation for years together. You can't give me an example of someone who is living with ventricular fibrillation from last 15 minutes. Because ventricle is not contracting, no ejection, no blood going to brain, you're gone within seconds to minutes. So summary is ventricular arrhythmias are more dangerous than supraventricular arrhythmias. Ventricular arrhythmias are fatal. Supraventricular can turn fatal, but otherwise they are much safer arrhythmias in comparison to ventricle. So that's why first thing I want to know is in a patient with tachyarrhythmias, whether it is ventricular or supraventricular. And for that, what will be my approach? Remember, whenever an arrhythmia originates in the ventricle, it will have wide QRS. If an arrhythmia is originating in the ventricle, its QRS will be wide. But if the arrhythmia is originating above the ventricle, supraventricular, it will have normal sized QRS. Normal sized QRS. So that's why whenever I have a tachyarrhythmia, the first thing I should see is what is happening to the QRS complexes. First thing I should see is what is happening to the QRS complexes. If the QRS complexes are wide, that means I am dealing with a ventricular arrhythmia. Wide. And if it is narrow, that means I'm dealing mostly with the supraventricular arrhythmia. Now comes the question, when do I call it as wide? What is the normal QRS duration? The normal QRS duration is 80 to 100 milliseconds. So in any case, the normal QRS duration should be less than 120 milliseconds. Normal QRS duration should be less than 120 milliseconds. That means from the onset of Q to the end of S wave, it should not take more than 3 small squares, right? One small square is 40 milliseconds, so it should take less than 3 small squares. So if I am dealing with a tachyarrhythmia where a patient's heart rate is more than 100 per minute and I see wide QRS, that is QRS duration more than 120 milliseconds, more than 120 milliseconds or more than 3 small square. It is suggestive of ventricular arrhythmias, and such arrhythmias we will call it as wide complex tachyarrhythmias. Complex here refers to QRS, so we'll call it as wide complex tachyarrhythmias or wide complex tachycardias, usually abbreviated as WCT. So in such cases, my differential diagnosis is ventricular tachycardia, ventricular fibrillation. Only catch point here is, what if my QRS duration was already wide? For example, we were talking about WPW syndrome. In WPW syndrome, there is wide QRS. And on top of that wide QRS, like we were talking about this example, right? WPW syndrome can cause AVRT. WPW can cause AVRT. But as part of normal ECG itself in WPW, we will have a short PR interval, a delta wave, right? And then wide QRS. QRS is already wide. And on top of that, if a re-entry circuit triggers an atrial arrhythmia, my arrhythmia will look like wide QRS because my QRS pre-existingly was wide, right? Pre-existingly, it was wide. So such arrhythmias can be confusing. We will call them as, they are supraventricular arrhythmias only, SVTs only, but with an aberrant conduction pathway, right? So we'll call it as SVTs with aberrancy. Now, differentiating this from the normal ventricular tachyarrhythmias is a little tough task, not important for an undergraduate student. So we'll ignore it. For us as an undergraduate student, whenever I see a wide complex tachycardia, my priority diagnosis is VT versus VFib. But if the QRS complex are narrow, the QRS duration is less than 120 milliseconds, then such arrhythmias will be called as narrow complex tachyarrhythmias, right? We will call them as narrow complex tachyarrhythmias. Narrow complex tachyarrhythmias or narrow complex tachycardias, usually abbreviated as NCT. Okay, so now under this, what all comes? Of course, we know that sinus tachycardia comes. Then we have atrial fibrillation. We have paroxysmal supraventricular tachycardia. Under that, we have AVRT and AVNRT. Then we have atrial tachycardia. Atrial tachycardia. So these are my supraventricular arrhythmias or narrow complex tachyarrhythmia. So far what we know, if I have a tachyarrhythmia, heart rate more than 100, deviation from the normal sinus rhythm, first thing I should see is what is happening to the QRS duration. If QRS appears to be wide, I would think of ventricular arrhythmias. If it appears to be narrow, I will think of the supraventricular arrhythmias. Okay, so that is point number 1. Point number 2. This we will discuss later. It's not very difficult to differentiate between VT and VFib. How do I differentiate between these narrow complex tachyarrhythmias, sinus tachycardia, atrial fibrillation, PSVT, and atrial tachycardia? Okay, so the next important thing that will help me to differentiate is the presence or absence of T waves, right? So we will today discuss the approach to narrow complex tachyarrhythmias, and tomorrow we will discuss a little more about individual arrhythmias. So if I'm dealing with narrow complex arrhythmias, that means I have heart rate more than 100, heart rate more than 100 per minute. That is where I call it as tachyarrhythmia, and QRS duration is less than 120 milliseconds. Okay. So in such cases, the first thing I should see is what is happening to P wave. P wave, Are they present, morphologically distinct and identifiable? Confidently, we can call it as the P waves or not. If P waves are present, what are the possibilities here? If it is sinus tachycardia, P wave should be present or absent? SA node has increased automaticity, so it is firing more frequently. It is sending the wave of depolarization across the atria, so atria is contracting, so of course I will have P waves. So in sinus tachycardia, P wave will be present. Okay. The second abnormality we spoke is atrial tachycardia, right? In the name itself, we're telling that atrial rate is increased. So that means atria is getting depolarized. If it is getting depolarized, causing contraction, there should be P waves. So P waves will be present even in atrial tachycardia. But the atrial fibrillation and the paroxysmal supraventricular tachycardias are the conditions where the P waves will be absent. So in AFib and PSVT, we will not have the P waves. But P waves are present in sinus tachycardia and atrial tachycardia. So the next thing, when I have narrow complex tachycardia, I should see whether P waves are present or absent. So if it is absent, what do I think of? If it is absent, my differential diagnosis is paroxysmal supraventricular tachycardia and AFib. And if they are present, what are my differential diagnosis? If they are present, I have differential diagnosis of sinus tachy and atrial tachycardia, right? And atrial tachycardia. These are my two conditions where I will have P waves present. Okay, let us concentrate on the situation. I got a patient with some palpitations, heart rate was more than 100. I looked at the QRS, that's my first step for arrhythmias. It turned out to be less than 3 small boxes. So now I know it is a narrow complex tachyarrhythmias. I looked at P waves. I'm not able to find P waves. So then these are two differential diagnoses that I should keep in mind, PSVT and atrial fibrillation. The question is, how do I differentiate between these two? So for differentiating between these two, all I have to see next is what is happening to the RR interval. From beat to beat, if RR interval is constant, right? Like P waves are anyway absent, the QRS complex is narrow. From beat to beat, RR interval is constant, appears to be at same interval, then it is most likely PSVT. But if the RR interval varies from beat to beat, right? Here it is less, here it is more. So RR interval is varying with absent P waves. We will call it as atrial fibrillation. Atrial fibrillation. If RR interval is constant, it is not varying from beat to beat, then my diagnosis becomes paroxysmal supraventricular tachycardia. And if RR interval is varying, then my diagnosis becomes atrial fibrillation, right? So if it looks like this, again, don't go by my sketch. It seems kind of varying, but presume that it is constant, then it is PSVT. If there is a clear-cut variation in the RR interval, then it is atrial fibrillation. So how do I approach arrhythmias? If I'm suspecting tachyarrhythmias, I will look at the QRS complexes. If it is narrow, I think of supraventricular. If it is wide, I think of ventricular. If it is narrow, then it is supraventricular or narrow complex tachyarrhythmias. Then I have to see whether P waves are present or absent. If they're absent, it can either be PSVT or atrial fibrillation. To differentiate between that, I will look at the RR interval. In PSVT, RR interval is constant, doesn't change, and in atrial fibrillation, it is RR interval is varying. So that is how I will differentiate between PSVT and atrial fibrillation. Now coming to this side, if P waves are there, complexes are narrow, heart rate is more than 100, but P waves are also there, then I have sinus tachycardia and atrial tachycardia. So how will I differentiate between these? We have already learned what is sinus rhythm. Remember, sinus rhythm is where the SA node is the dominant pacemaker, and if SA node is the dominant pacemaker, it is sending a wave of depolarization to atria, so there should be P waves present. And because there is no other pacemaker in the sinus rhythm, each P should be followed by one QRS, or behind a QRS, there should be a P wave. And this is how I define it as sinus rhythm. When heart rate, rhythm being sinus, but heart rate is more than 100, I'm calling it as sinus tachycardia. So the first three rules will apply even for sinus tachycardia, right? There should be P wave and each P should be followed by QRS. Thus, P by QRS ratio will be 1, right? But if I have atrial tachycardia, atrial rate is higher than the ventricular rate. So the number of P waves in atrial tachycardia will be more than the number of QRS complexes. So that's why if P waves are present, the next thing I should see is whether each P is followed by a QRS, or in other words, P by QRS ratio is same, right? So if the number of P waves is equal to the number of QRS, then it is suggestive of sinus tachycardia. But if the P waves are more than the number of QRS complexes, then we will call it as atrial tachycardia. Atrial tachycardia. So this is how we are going to approach the narrow complex tachyarrhythmias. Okay, just to give you an example, let us say we are dealing with a patient with atrial tachycardia, where atrial rate is so high in comparison to ventricular rate, right? Let us say the atrial rate is 200, ventricular rate is 50. So then what will be the P by QRS ratio? If atrial rate is 200 and ventricular rate is 50. So if atria is contracting 200 times, the number of P waves will be 200, and if ventricle is contracting 50 times, the number of QRS will be 50. So if I look at the ratio, it will turn out to be P by QRS ratio will turn out to be 4:1, right? That means for 4 P waves, there is 1 QRS. So sometimes when I am dealing with an atrial tachycardia, where atrial rate is way higher than the ventricular, the ECG may kind of look like this. Atria contracts P wave, atria contracts P wave, atria contracts P wave, atria contracts P, okay. Atria contracts P wave, atria contracts P wave, and then one ventricular contraction appears, atria contracts, atria contracts, atria contracts, and then ventricular contraction appears. In such cases, this hole may create an appearance of what we call as sawtooth, right? If I look at the baseline, it kind of looks like the sawtooth. We can call it as sawtooth appearance. So in that case, we will call it as atrial flutter. So can I say atrial flutter is a subtype of atrial tachycardia? Yes, atrial flutter is a subtype of atrial tachycardia. So more on the individual arrhythmias tomorrow. So today I hope we have given a gist. So download this notes and then hold some ECGs today. Try to apply what we have learned today and see if you can reach the right answers for arrhythmias. Tomorrow we will learn individual arrhythmias, starting from the PSVT, AVRT, AVNRT, atrial fibrillation, VT, VF, all of them, and how to recognize them on the ECG in detail, right? So that's it for today. Please remember this approach. This is going to be the groundwork for all your questions on the arrhythmias, whether it is ECG based analysis or the description based analysis. And if you stick to the protocol, trust me, you will not go wrong on the arrhythmias. Most of the times what happens is students want to deviate from the protocol. I gave you an approach starting from the basic tachyarrhythmias. How do I differentiate between wide and narrow? Then if it is narrow, how do I proceed further? But most of the students jump this protocol and end up with the wrong diagnosis, right? So we'll discuss more on individual arrhythmias. We will apply the protocols with the real ECGs and then discuss tomorrow. Kiran Sangpal, yes. So we are taking up individual arrhythmias from now onwards. This is the groundwork that we had to do to be able to understand those arrhythmias in detail. So from tomorrow, we'll take individual arrhythmias, the ECG diagnosis, as well as the management. We will have a little detailed discussion on the atrial fibrillation because there is also a role for anticoagulation and deciding anticoagulation in that. Well, from tomorrow, we will begin. We will probably have 2 sessions or 3 sessions to complete all our arrhythmias. And with that, our basic ECG will be covered. We will have 1 session for some special ECGs, and then we will wind up the. Okay. So that's it for today. See you soon.